Hello. Can y'all hear me?
Yes, I can.
There you go.
Excellent. Excellent. All right.
Sorry, guys.
Made it through some technical challenges here. Hey, Candy, how are you?
Sorry. Everybody's already met Dr. Rami Apelian.
Hello, everybody.
Huntington headache and neurology. Speaking on epilepsy and aging. Did we already do that? Do we know? Thank you. Thank you.
Absolutely.
Go
It's
for
great
it.
being here. All right, so ready to start?
This is you.
All right,
You want to
let
wait
me
a couple of
start
minutes to
sharing.
see, or you want to just start?
I'm ready to start. I just need to be able to share my screen.
Okay, 1 second, because I don't know how to do that. Share. 1 second.
You have to make them a co-host. Make them a co-host.
Oh. Just wait.
Go to more for participants.
I don't know.
Go to screen. Make that screen bigger.
This?
Yeah.
Settings.
Okay. Okay. Go to settings. Where's participants?
Nope.
Okay. Exit.
Hang on.
Up here. Exit here.
Hang on.
Okay. You should be able to now. I just made you a co-host. Where's participant? Participant. Okay. There you go.
Yeah.
Hit him.
Where?
Where is he?
Host.
Yes. Go to. No, not. No. Go to participant.
Oh, here.
Yeah. More. Go to. Okay. Go to more.
Got it. 1 second.
Make co-host right here.
Woohoo.
There you go. There you go.
Yes.
Yes.
Oh, there
I did it. I am not a millennial. Go for it.
We did it. All right. Let's add that
Go.
here. And we're going to share that. All right. We see the slides. Yes. Okay. Candy's giving me a thumbs up. All right, everybody. Thank you very much. It's glad we worked through some of those technical challenges. It's great to be here at Epilepsy Awareness Day Online and Interactive. We're going to launch this. I get to kick this thing off. That's pretty cool.
Y'all ready for this?
I lost audio. That was supposed to be a fun little intro to kick us off. Alas, it didn't work. All right. So those of you who know me, my name is Rami Apelian, and those of you who don't know me, my name is Rami Apelian. I'm a big fan of USC football, and that was supposed to be our little kickoff introduction. It did not go off as well as I expected. But the reason I bring this up is because now November 2nd, first week of the month, that's very exciting.
Y'all ready for this?
Number one, obviously we are here to talk about epilepsy and to educate our community about the disease state. We are also here to remind ourselves that tomorrow is election day, and more importantly, here on the West Coast, this is the week of actual football kicks. So no disrespect to my colleagues, Dr. Fisher at Stanford, Dr. Sankar, Dr. Elliot Schiff, Dr. Stern at UCLA, but quite honest. So today we're here to talk about epilepsy and aging. A few things just up front I want to disclose. I am associated with multiple pharmaceutical and medical device companies. The whole list can be found on my CV at our website, but really this is not going to impact any of today's content. Now, before I start talking about epilepsy, before I start talking about the medical disease state, there are some definitions I think we really do need to clarify. And, you know, these are words that probably have been heard over the course of the last 9 months over the COVID pandemic, and these are words that have become more and more familiar to everybody. But I think it's important just to take a minute out here and really define what it is we're talking about. So the term epidemiology is something we've heard, and really this is the study of where, when, and how and why a disease goes from person to person or exists in a community. And so when we talk about the epidemiology, there are a number of different parameters that we look at. We look at something called the prevalence, which is how much of the population has the disease state at any given time. There's also a little nuance there. There's something called the lifetime prevalence, which is the proportion of a population or a proportion of people who have the chance of having this disease in their lifetime. And it's important because the Epilepsy Foundation has given us some data about the incidence and prevalence of epilepsy, and I just want to make sure everyone understands what these numbers mean. Now, I just used the word incidence. What does that mean? That's the likelihood or the occurrence of new cases in a population over a specific period of time. So when we're talking about key epidemiological terms, prevalence and incidence are really the two big ones. And so that said, I want to just kind of take a moment now and describe the epidemiology of epilepsy. So according to the Epilepsy Foundation, 1 in 26 people will develop epilepsy in their lifetime. In the United States, 3.4 million people had epilepsy in 2015. And we're getting about 150,000 new diagnoses of epilepsy per year. Now, worldwide, that number is obviously much larger, and we're talking about 65 million cases of epilepsy at one time. When we talk about the epidemiological terms and what those mean, the 1 in 26 people developing epilepsy in their lifetime is what we call the lifetime prevalence. The 3.4 million people at any specific period of time is what we call the prevalence. And I just think it's important that everyone understands what these terms mean so that we can not only understand what's going on with this particular disease state, but in a more relevant sense right now, also what's going on with COVID-19. Now, the importance of all this. Secondary to stroke, epilepsy is the most common serious neurological condition. And in adults who are newly diagnosed, they have a really hard time understanding that there's a risk as you age with developing epilepsy. In fact, the incidence of epilepsy in childhood is about 40 to 50 per 100,000 patients per year. But as you get older, that number goes up. And the likelihood that you'll have a first seizure between ages 40 and 59 is 50 to 60 per 100,000 per year. And the first seizure in incidence greater than 65 years old goes up significantly after that. And these numbers are likely underestimated because epilepsy is typically underreported. Why is it underreported? Well, a quarter of general practitioners aren't even aware that epilepsy can manifest for the first time in older patients. And in older patients, it is potentially life-threatening. You have a 2 to 3 times greater risk of injury or death than in the general population. The risk of SUDEP goes up, and we're going to talk about that a little bit. Status epilepticus is more likely to occur in an elderly patient and has a higher mortality, which means you're more likely to die from status epilepticus if you're older. And of course, there's the risk of physical injury with any seizure, whether that's a fall or some other physical injury that results. Older patients tend to be more brittle and be more likely to fall, independent of whether or not they have epilepsy. Now you throw a seizure into the mix, and it's a recipe for a broken hip, a broken shoulder, or a broken skull. It's also important to understand that older patients are the fastest growing age group in the United States. It is estimated that in the next 40 years, actually 30 years at this point, if you compare the numbers of patients who were above the age of 65, in 2012, we had 43 million individuals. By 2050, that's expected to almost double to 83.7 million people above the age of 65. And the greatest fraction among those growing numbers are patients above the age of 90. Life expectancy is getting longer, and so we are more likely to encounter older patients as time goes on. Now, I'm going to show you some of these epidemiological curves in a moment, but the greatest incidence of development of epilepsy is in patients above the age of 75. So it's really important that we actually focus on the older patient age group. So I want to just kind of quickly go over the outline for today's discussion. We're going to discuss the age profile of patients that develop epilepsy, and then discuss why it's important to control seizures and the risks of seizures at any age, why seizures are difficult to identify in older patients, and the pharmacological considerations across the ages. So we'll start with the age profile of patients. So in 1998, Dr. James Rowan did an epidemiological study to identify the incidence across each decade of life. And what he found was if the greatest incidence of developing generalized epilepsy occurred during childhood, and that number pretty much tapers off over the course of your adolescent and early adult years, and it starts to grow a little bit as you hit the age of 60. That's represented by the black line with the dark circles. Now, if we look at the incidence of focal seizures, now in 1998, they were called partial onset seizures. We now refer to them as focal seizures. The incidence of having focal epilepsy or focal seizures early in life was lower and steadily goes up until the age of 60, where it then shoots up. it didn't really matter if you're a male or female. The incidence of later ages. Now, this is data from 19. We all went into COVID lockdown that showed the worldwide incidence more recently, and the data actually is pretty similar. So that hasn't changed. So let's talk about the risk factors for epilepsy in the youngest patients. So that's typically developmental issues, things that could happen during pregnancy. So prematurity, with prematurity comes an increased risk of bleeding in the brain during birth. Abnormal blood vessels like arteriovenous malformations, for instance, can occur. Trauma during birth, such as cerebral, that leads to cerebral palsy, seizures associated with fevers and febrile seizures. A patient's family history of epilepsy or the incidence or the presence, of autism, all increase the risk for epilepsy in our youngest patients. And that's really what we see represented in the red box here in the early ages of life. Now, when we look at the younger patients, these are what I would say are adolescents till about the age of 45 or 50. Trauma and head injury are really the most common causes: automobile accidents, bike accidents, concussions. Those are really the biggest risk factor for developing seizures and epilepsy, as well as structural damage to the brain from substance abuse, drug use, toxins, etc. We also know that there are autoimmune causes that are less likely to occur, but when they do occur, can cause seizures to occur. So when we look at the early parts of life, and I say young patients, meaning under the age of 60, these are really the biggest risk factors that contribute to them developing epilepsy. Now, when we look at our older patients, and there's really no clear consensus of when late onset epilepsy exists. In some aspects of the literature, it is at 55, in some it is at 60, in some it is at 75. Generally speaking, I think using Medicare as our threshold here in the United States, 65 is what we do tend to identify as the cutoff for older patients or late onset epilepsy. And again, head injury or trauma is common. Stroke is the most common. Alzheimer's disease and other neurological diseases and neurodegenerative diseases can contribute. And so those are the patients that are represented here in the green box on the far side of our graph. So I talked about stroke as being the #1 cause of epilepsy in our patients above the age of 65. So this actually accounts for about half to 3/4 of the presence of new onset epilepsy in our older patients. And epilepsy typically will develop within a year of the stroke. If a patient actually presents with a seizure at the time of their stroke, that doesn't necessarily increase their risk of epilepsy because that is considered a provoked seizure. However, once the stroke settles, if you will, and the patient then goes through the rehabilitative process, the brain itself cools down from the stroke. If a patient does subsequently have a seizure, they are at further risk for developing epilepsy. And after a stroke, the risk of developing epilepsy is about 23 times greater than in the general population. Now, the early data suggested that a hemorrhagic stroke, that's to say a stroke that was associated with bleeding, was more likely to cause epilepsy than an ischemic stroke, which is the stroke caused by a blocked blood vessel. But now the data actually has shifted a little bit to suggest that ischemic stroke is actually higher risk than hemorrhagic stroke by about a ratio of 2 to 1. Neurodegenerative disease is also very important. Alzheimer's disease is really the most common that we see and accounts for somewhere between a 10th and a 5th of new onset epilepsy in older patients. I mentioned trauma. This can be up to 1/5 of new onset epilepsy patients, typically as a result of bleeding in the brain from a fall. And seizures are often the first presentation that a patient actually has a brain tumor. Obviously, we can't look at a patient and see inside their skull to know if they have a brain tumor. And in the absence of any focal neurological deficits, that's to say any weakness or any sensory changes or any speech problems, it's hard to know that anything's going wrong. Well, when that brain tumor aggravates the brain or irritates the brain enough, a seizure can occur, and that's usually when the patient ends up abnormal as identified. So, the risk factors of seizures at any age. Now, obviously, a physical injury as a result of a loss of consciousness is something we have to consider. In pediatrics, this can manifest as a fall. In adult patients, this can also manifest as a fall. But again, older patients tend to have osteoporosis or osteopenia, and so physical injuries are a very significant concern. In patients that are old enough to drive and have had stable seizures and are able to drive, a episode of a loss of consciousness obviously does increase the risk of car accidents. So maintaining seizure control or preventing seizures with adequate medication or surgery is important in order to reduce the risk of physical injury to both the patient, the occupants of the vehicle, and the community. Drowning is a significant concern. This is why we tell our patients to be careful and not enter a jacuzzi or a bathtub alone until they know that their seizures are well controlled. If you lose consciousness in a body of water, there's a high risk that you will stop breathing if underwater. As a patient's epilepsy becomes more and more refractory or less responsive to medication, there's always a risk of having more medications on board. And that can lead to drug-drug interactions. It could lead to side effects accumulating between medications. So really addressing seizures early and trying to get control early with the lowest number of medications is favorable for a patient. The most common side effects of nearly all seizure medications include dizziness, somnolence, and drowsiness. So we have to warn our patients, especially those that are driving, to be careful until they know how the medication makes them feel. And the more drugs you add on, the more likely you are to experience an accumulation of these side effects. There's also psychological problems that are associated with epilepsy, namely depression. And depression is really the most common comorbidity that occurs in patients with epilepsy. And as we've all begun to experience as a result of COVID-19, a lot of that has to do with a lack of control. And this cartoon called Johnny Optimism, this was, I kind of show this at a number of my talks. This young boy walks up and is asked, "Hey, you must be the new kid with bad epilepsy." And he says, "Yep." And there's a pause. And the kid says, "Suspenseful, isn't it?" And the other kid says, "Heck yeah." But I mean, at the end of the day, this is really what our patients experience. It's a lack of control. And it is easy to become sad or depressed if you aren't able to control your disease state. So that said, refractory epilepsy is something that really we have to monitor our patients for depression and for suicidal thoughts. Every single seizure medication on the market comes with a warning to monitor our patients for suicidal thoughts and depression. And that's because studies have shown that if you are on a seizure medication, you are likely, about 2.5 times as likely to have these thoughts compared to someone who is not on this medication. And of course, there's the most significant consequence of uncontrolled seizures, and that's death. And I want to take a moment to talk about SUDEP, which is the sudden unexpected death in epilepsy. So sudden unexpected death in epilepsy is going to affect about 1 in 1,000 people with epilepsy. And basically, the more uncontrolled your seizures are, the more likely you are to experience SUDEP. It's the leading cause of death in young adults with uncontrolled epilepsy. And as I mentioned, as we age, the increased age is associated with an increased risk of developing SUDEP. And we don't exactly know why. One potential possibility is that since seizures are not as well recognized in adults above the age of 60, patients are more likely to go into status epilepticus or experience SUDEP because their seizures aren't exactly identified. Now, these patients are typically found in bed, prone, without evidence of a convulsive seizure, and are dead. And right now, the best prevention we have is to continue to control those seizures. How are we doing on time? Oh, good. We're about halfway done with the talk and about 25 minutes through, so I think we're doing okay. All right, so why are seizures difficult to identify in older patients? There's a video that I have for today, and I really hope I can get the audio through. Let's take a look here.
Okay, well, what happened yesterday?
Well, it was no big deal. We were having a dinner, and then we went into the living room, and we sat to talk a while. But then, well, I don't know.
Yeah, much
how to
like my big
explain it,
intro, can't get the audio
something,
to come through here, and I think this might
something
actually
didn't
just be a
feel
host
right,
setting.
and,
So let me just kind of talk you through this visit.
I didn't know
So this is a
where
generic
I was,
office
and
visit. I
didn't
found
know
this
what we were
video on
talking
YouTube,
about,
and
I
I
felt
find it to
like,
be actually
I was
very
watching myself,
compelling.
like in a movie, and
We
Doctor
daughter in
that during a
front of me
family
and talking
gathering,
to me.
he
What did you say?
suddenly felt
Well, my
off,
dad got this
and
faraway look
his
in his
daughter
eyes,
reports
and I
that
could tell that he
you know
had
she
stopped
saw her
listening to
dad
me.
staring
So
off,
I
and he
asked
may
him
have
if
had
he
a
was
little.
okay. He didn't respond. He was just kind of looking around, and I noticed that his left hand was shaking a little bit, and then his left foot.
All right, I'm back. My system crashed. Can you guys hear me or see me? Anyone?
Yep.
All right, sorry about that. See, this is what happens when you try to incorporate too much technology into a presentation. So I apologize for that. So anyway, I'm gonna go back to that video that I tried to show you that took down our meeting, and I apologize for that. But to kind of walk you through, there was a doctor's office visit. There was an older gentleman with his daughter, and they were describing an event at a family gathering, which is so 2019, where they were sitting down and talking to Dad, and all of a sudden Dad said he just felt a little weird. He felt this kind of an out-of-body experience where he was looking at himself. His daughter said that when she tried to call his name, he was a little less responsive. She may have seen some shaking in his hand or some twitching. The whole event lasted about 30 seconds or a minute, and then afterward, the patient said he was tired and he wanted to go lay down. He just attributed it to a dizzy spell. And the daughter's asking whether or not this is something that needs to be investigated. Well, this is a pretty typical scenario where patients are actually coming to the doctor with recurrent spells that aren't really well classically described. They do have the same presentation time and time again. However, they are not convulsive events, so they are very difficult for family members to identify as seizures. Now, children are never alone, right? So there's always a parent or a teacher or a caregiver that's present. So if something happens to a child, there is someone that sees the event and is able to describe a suspicious event. Adults, typically those that are more affluent and have the opportunity to live alone, are often alone. So these events, as they occur, are unwitnessed. Again, also seizures in older patients don't tend to be generalized. They're more likely to be focal onset, just like I showed you on the epidemiological data earlier. So that said, the classic full body convulsion, urinary incontinence, tongue biting. These are more likely to occur with generalized seizures and are not likely to occur in an older patient who is having a seizure. So these may not be recognized. So really, these are more subtle events, and oftentimes they're described as dizzy spells, or the patient had an alteration in their mental status. Those are not very specific descriptors, but these are oftentimes what we hear either from our colleagues who are referring the patients to us, or from the patients and their family members. Family members may describe staring spells or periods where the patient is not fully responsive. Sometimes this could be attributed to inattention. Oh yeah, dad's zoning out again. This can also be confused with dementia, as patients who have lapses in consciousness are naturally going to have gaps in their memory and gaps in their recollection. And family members often attribute this to something more commonly understood in their minds, such as Alzheimer's disease, or simply attribute it to confusion associated with aging. Now, in younger patients after a seizure, typically a post-ictal period, that's to say the time after the seizure, can last from anywhere from minutes to hours. However, in adults, this can actually, in older adults, the post-ictal period can last days. And so after an event, the patient's going to be tired and may not return to their functional level for 24 or 48 hours. So what family members will report to you is that, for a couple of days, mom was just not herself. And of course, there's a lot of things that look like seizures that we have to make sure that we're not misdiagnosing a patient. A fainting spell, or like I said, a confusional state associated with aging. The presence of tremors. Oftentimes, if family members see a rhythmic shaking, they may attribute it to tremor, and the patient will be referred for evaluation of Parkinson's instead of an evaluation for epilepsy. So it's really important for us as physicians to ask the right questions to try to figure out what is it we're actually dealing with from a medical standpoint. Sleep disorders. It's interesting. Patients who have sleep apnea or sleep deprivation are more likely to have seizures if they have epilepsy. So oftentimes patients are younger, their epilepsy is controlled, and as they get older, they develop risk factors for sleep disorders, and all of a sudden their seizure threshold changes. That's to say they're more likely to have a seizure because they're not getting restful sleep or have other sleep disorders. So that can actually reactivate someone's epilepsy. And other sleep disorders like narcolepsy or cataplexy, where patients suddenly fall asleep or have complete loss of postural tone and drop to the ground, are often misinterpreted as drop attacks. So it's important to differentiate those. And stroke or TIA being what we call a mini stroke in colloquial language, can also be misinterpreted as epilepsy, particularly if a stroke presents with a seizure, which it can. And of course, polypharmacy. As patients get older, they're on multiple medications. And these medications, as I mentioned, can have drug-drug interactions. And they can also have additive side effects that can cause confusional states or other cognitive changes and memory problems that are misinterpreted. So with that said, let's talk about medication for a minute. And medication, not just for epilepsy, but really just medication and aging. The question I often get asked by my patients when we talk about starting medication is, which medication is right for me? It's important to understand that there is no single ideal anti-seizure medication that exists for every patient. And I really want to reemphasize this point, and I'm going to using bold, and I'm going to keep that bold. And the reason that there is no single ideal anti-seizure medication for every patient is that nearly all seizure medications are associated with these three common side effects: problems with drowsiness and sedation, what we call the cerebellar side effects, which can affect your balance or vision, as well as I mentioned drowsiness. You also have to monitor patients for mood problems and memory problems because a lot of seizure medications have these common side effects. Some of the older seizure medications are also associated with development of long-term other medical issues, polyneuropathy, bone marrow suppression, decreased platelet counts, decreased bone health, osteoporosis and osteopenia. So fortunately, some of the newer medications that we have available have similar, what we call efficacy. That's to say they work just as well, but they're associated with less monitoring and less side effects. So although that last bullet point is less of an issue now, it is certainly something that needs to be considered as well when patients don't have access to newer medications. Aging also affects how medications work in the body. Every organ becomes less efficient as we age. Patients are used to their hearts becoming less strong. They're used to their kidneys not clearing as well. They're used to their liver not working as well. So how do you describe to a patient that their brain also is undergoing changes associated with age? Well, this is something I actually talk to with my patients all the time. I like to tell them that, as we age, all of our brains shrink. And as our brains shrink, the wiring also changes. When the wiring changes, that also increases the risk for seizures and epilepsy. It can also cause our brain to respond to medications differently. So there's a lot that goes with aging that, particularly with the use of medication, that we don't fully understand. How one absorbs the medication through their gut, how the liver processes the medication, how the kidney either processes the medication or excretes the medication, and then how the brain responds and what the side effect profile is for any given patient can be very different from patient to patient in elderly patients. In pediatric patients, when a drug is getting a pediatric indication, the safety profile and the pharmacological properties of any given drug are studied pretty extensively. However, the clinical trials we have for adult patients typically do not have a large number of patients above the age of 65 in the clinical trials. So we're often left to try to figure out what medication is actually right for the patient with very little data. It's also important to understand that certain medications only work on certain seizure types, so it's important to identify a correct seizure type, and that some seizure medications can actually worsen certain types of seizures. So again, it's important to identify what is the correct seizure type. Dosing in pediatric patients, I mentioned, is weight-based, and there's extensive information and studies that go on to determining those doses, but in adult patients above the age of 65, that really does not occur, and they represent a small fraction of patients studied in the clinical trials. Another risk factor, as I mentioned, is that older patients tend to be on more medications. As we get older, we rely on more medications in order to be able to control our general health. So this increases the risk of drug-drug interactions. This increases the risk of any individual drug having side effects and the accumulated side effect profile between the multiple drugs. Patients, as they age, also do have cognitive problems. And oftentimes, as their caregivers age, they too have cognitive problems. So this can actually lead to some challenges that we don't really think about until we have to experience it as physicians. And it's, did the patient even remember to take their medication? Is their epilepsy not controlled because they're forgetting to take their doses? Or more importantly, are we doing an adequate job of teaching our patients how to take their medications and ensuring that they adequately understand how to dose their medications? A lot of seizure medications require slight dose escalation and titration from 1 week to another to try to get to the correct dose. And so it's important that we ensure that our patients are actually following our instructions well. And so with older patients, I tend to ask younger family members to be present at the office visit, as well as to be more engaged in their care. an interesting phenomenon with COVID-19 is that because older patients are more susceptible to the effects of COVID-19, a lot of younger family members have now gotten to be a little bit more involved in my older patients' healthcare, which actually I think has been great for my patients. And really, it's something that now I'm implementing, if you will, as part of my treatment for my patients, is to make sure that their younger family members are more involved. So that actually takes us through the topics I wanted to discuss. Unfortunately, with the loss of the videos and the kickoff, we shortened the presentation a little bit, so we have a little bit of extra time. I do want to thank all of you for your attention today and your commitment to epilepsy, and also just remind everybody that tomorrow is election day, and I want to thank everyone for their attention right now. I'm going to turn off the screen share, and I'm happy to open things up to questions if we can get that working. So thank you. All right. Can you all see me? Can you all hear me?
Yes.
All right, excellent, excellent. I see there's about 10 bubbles here in the chat. Let's see, I'm sure this has to do with what happened. Why did things go black a little bit earlier? Yep, sure does. All right.
Excuse me, I
Yes,
have a
hi.
question.
All right, hello.
Hello, are you hear me?
Yes, I can.
Okay. What happened if the patient they forgot take the medication and they have the seizure? So after that, can we give directly give the medication and see the patient forgot to the patient to take after the seizure?
So that's a great question, and just to recap, in case anybody didn't hear, the question was, if a patient has a seizure because they did not take their seizure medication, when is it okay to go ahead and give them their seizure medication? And the answer is, it actually depends on the medication. And some medications last a long time in the body, and you don't want to give too many doses too soon. Some medications are a lot shorter acting than others, and so you can safely add the extra dose. It is actually very important that you talk to your doctor about what type of medication you're taking and when it's okay to take an extra dose. Generally speaking, yes, it is okay to take an extra dose to make up for the lost dose, but that is not always the case.
And I also have another question.
Yeah.
And you say for the patient over than 65 years old, we don't have a lot of clinical trial to study for the side effect. But so do we have to keep monitor what is the common side effect on the patient? Or I don't know what happened for this patient. How we make sure it's good for patient.
So so again, if anyone didn't hear the question, it's, as I mentioned, we don't have a whole lot of data for how these medications work in our patients above the age of 65. So are we supposed to constantly monitor our patients or our family members who are on these medications for side effects? And the short answer is that typically side effects occur more likely to occur during the initiation of a medication rather than the continuation. So typically within the first month is when you're going to see most of these side effects. But truthfully, side effects can occur at any point. So I typically tell my patients, I really want you to be vigilant and really watch your family member closely for the next couple of weeks. Call me if you have any questions. Some of these side effects are likely to go away. Some of them are not. So let's understand what it is that's going on. But obviously, the one thing that we want to be most concerned about is to make sure patients aren't falling. So I have a question here. Is there any chance we can get access to your presentation files or PowerPoint? Absolutely. I'm happy to share those. You know what? I think I could probably just upload it to the chat here now that I think about it. Let's see if I could do that. I've already tried enough technology today. I really hope I don't mess this up. see. There it is. So I am uploading. Oh, I uploaded it to private. I'm going to go ahead and upload it to everyone. I apologize there. Let me do that again. All right. Epilepsy and Aging. There we go. All right. So I have actually uploaded the PowerPoint from today's presentation into the chat. So if anybody wants to download that, that's yours. It's just taking a little while here. So be patient with it. I won't close the meeting so that you guys can get access to that.
Well, while we're waiting, can I ask a question regarding focal onset epilepsy and age and living alone? What do you think? I know what my family thinks.
I'm sorry, Janice. I appreciate you asking the question, but I can't really hear you very well. I heard the "what do you think" part. Can you repeat it?
I'm in a group, please, though I can't, you have to use the microphone.
No, that sounds much better. Thank you.
Focal onset, living alone, aged. What should we do? I have a service dog, which is the best. You know, little angels are the best people in the world, but that's okay.
No, I mean, service dogs are wonderful. I totally agree with you. Dogs in general are wonderful. But the question from Janice here is, in older patients who are living alone who have focal onset seizures, you know, what do you do? And the short answer is we try to actually control the seizures as much as possible, first and foremost. Typically, adult patients who develop epilepsy as a result of the aging process or as a result of neurological injury tend not to require as much medication as some of our younger patients who develop epilepsy. So the good news there is that it's a lot easier to achieve control. Now, the challenge here is that what happens if we don't know if there's control? There's a lot of implications here, particularly in a patient who's older and functionally independent and driving. So it's important to actually make sure that we know that there aren't breakthrough seizures occurring. So sometimes monitoring at home using an ambulatory EEG is appropriate. Currently, you know, in the COVID setting, I probably would not recommend coming into the hospital for EEG monitoring to see if there are any breakthrough seizures. But really, I think the clinical presentation more than anything is going to help guide you. And if suddenly you have an older patient who's living alone and they're more forgetful, they're starting to fall, family members are wondering what's going on, that's a reason to start looking into it again.
And you mentioned a lot of possibilities of cause. How often is a cause not identified?
It's a great question, and you know, I don't think that we actually have a great answer to that. The reason for that is that the technology is evolving and our understanding of the disease state is evolving. So what falls into what we call the idiopathic category used to be as high as 20%. That said, I think we're getting better about it, and that's also because that we're getting better at identifying the comorbid or associated disease states in older patients. Thank you. I have a question here coming in through the chat. So it says, I don't see the link in the chat. Did you send it? There should be a file that is about 1, 2, 3, 4, 5, 6 above our current point in the chat for everyone. So Cindy, if you don't see that, let me know. And then I have a question coming in here from Christopher. It says, hi, Dr. Apelian. I'm 34. I have focal partial complex with generalized seizures, generalized epilepsy. My seizures switch from daytime, generalized mostly to nighttime. Is this common? Can they switch back at any time? So, you know, Chris, thank you very much for sharing that. And, you know, everyone's seizures are different. Everyone's epilepsy is different. And as your epilepsy evolves, yes, your seizures can change. You know, whether or not there's any predictability as to whether or not that is going to change and go back to a daytime phenomena is tough to answer, particularly because there are different epilepsy syndromes. There are, like you said, you can have generalized epilepsy and focal epilepsy. So the question is, which seizures are occurring at night? We do know that seizures are more likely to occur as patients transition into sleep or deeper into stages of sleep. So it is not uncommon for seizures to be more frequent at nighttime. So it really just depends on the clinical scenario, and I encourage you to discuss this with your neurologist or your epileptologist. Okay, so Cindy just came back and says, I apologize, I just don't see it in the chat thread anywhere. So Cindy, I'm just going to go ahead and send, oh, you know what? I see why. So Cindy, you can't receive files. So my guess is that you may be on a mobile device. And Adriana said the same thing. Yeah, Cindy is on. All right, so I will coordinate with the event coordinators to make sure that a copy of that PowerPoint slide is present, and maybe go through the help desk to try to get a copy of it later today, if that's okay. All right, also one more question. As I get older or each seizure occurs, can your memory get worse or get damaged more? So we know that the more frequent seizures you have, the more likely you are to develop further seizures. It depends on which part of the brain is involved. If you have a seizure, you are likely to forget the episodes that surround that individual seizure. Whether or not that could be predictive of worsening memory moving forward really depends on the type of seizure, the frequency of seizure, and the location of the seizure focus. Okay. We have a few more minutes, so I'm happy to open it up for some more questions here in the chat or with the microphone if anyone wants to speak up. Oh, here's Cindy. She says, do we have any data or understanding about why patients have difficulty finding the word they're trying to say? So the question about word finding difficulty is tricky. There's a lot of different reasons patients can have word finding difficulty. One of the most common is a medication side effect. Word finding difficulty is commonly associated with the use of topiramate or zonisamide. Also, depending on where the seizure focus is in the brain, there could be a possibility that there's an electrical disruption resulting in word finding difficulty. The question specifically now asks about lamotrigine. So lamotrigine can have some cognitive side effects. Depending on what dose you're on, what other medications you may be on, it may be important to talk to your neurologist or epileptologist.
That's interesting.
All right, I'm just going to give it about 30 more seconds.
I downloaded the file and I am unable to open it. It comes up, it's, you download it as a PPTX, but I cannot open it. So are you going to, did you say you were going to have it somewhere else?
So I'll get in touch with the help desk and see if I can give them a copy of the PowerPoint or email it to them so that you could reach out to them and perhaps get a copy of the presentation for your records from them, since we're having a hard time transferring the file through the meeting here. Well, so this has been fun. It's been obviously a very different experience, and we got to experience the technical challenges of getting online in the first place, and then of course the meeting crashing because I decided to try to get a little bit fancy with my PowerPoint. So that all said, I want to thank everybody for their time today, their commitment to this disease state. I want to thank Brad and Candy Levy. I want to thank Sophie's Journey and all of our corporate sponsors today, and thank all of you for your time and your wonderful questions. And look forward to continuing to work with this group and this event and really support our community. Thank you guys so much.
Thank you,
Thank
Dr.
you so much,
Apelian.
Dr. Apelian. Thank you.